In rheumatology, pulse therapy refers to the administration of doses of medications over short periods of time, typically to control severe inflammation quickly or during disease flares. The most commonly used drugs for pulse therapy in rheumatology include 1. Corticosteroids, e.g., methylprednisolone. These are given in high doses, often intravenously, to rapidly control inflammation in conditions like lupus, rheumatoid arthritis, vasculitis, and systemic sclerosis. A common regimen might be 500 to 1,000 milligrams of methylprednisolone given intravenously over 3 to 5 days. 2. Cyclophosphamide. This is an immunosuppressive drug often used in pulse form, particularly for severe vasculitis, lupus nephritis, or systemic sclerosis. It helps control the immune system's overactivity and is usually given alongside corticosteroids. 3. Methotrexate. While more commonly used in weekly low doses, methotrexate can be given in higher doses, subcutaneously or intravenously, as part of pulse therapy in certain situations, especially in severe rheumatoid arthritis or systemic vasculitis. 4. Rituximab. This monoclonal antibody can be used in pulse regimens for diseases like rheumatoid arthritis, systemic lupus erythematosus, and NC-associated vasculitis. The dosing is typically given in pulses, e.g., 1,000 milligrams on days 1 and 15. 5. Intravenous immunoglobulin, IVIG, used in conditions like dermatomyositis, Kawasaki disease, and autoimmune neuropathies. IVIG can be given in high doses over short periods as part of pulse therapy. These pulse therapies are often used to induce remission or control severe disease activity, and their administration is typically followed by lower maintenance doses or alternative therapies.
Here's some important comments. First, the corticosteroid pulse therapy is used with very high precaution in systemic sclerosis for fear of scleroderma renal crisis. Second, methotrexate pulse therapy in high dose intravenous or subcutaneous is rarely used nowadays due to the era of biological drugs. Uh, and the AI said that it is ANSA associated vasculitis. It is ANCA, not ANSA. ANCA, anti-neutrophil cytoplasmic antibody, ANCA, is read ANCA associated vasculitis.
Pulse steroid therapy involves the administration of high doses of corticosteroids over a short period, typically intravenously. It is a critical treatment strategy in rheumatology for quickly managing severe inflammation and preventing tissue damage in autoimmune or inflammatory diseases. Key features of pulse steroid therapy. 1. Common steroid used. Methylprednisolone is the most commonly used corticosteroid for pulse therapy. Dosing. Typically, high doses, e.g., 500 to 1,000 milligrams per day, are administered intravenously over 3 to 5 days. It is given to rapidly suppress immune system activity and reduce inflammation. 2. Mechanism of action. Corticosteroids reduce inflammation by inhibiting various components of the immune response, including cytokine production, leukocyte migration, and the release of inflammatory mediators. Pulse therapy delivers steroids in higher concentrations, enhancing the suppression of the immune response more quickly compared to standard oral dosing. 3. Indications. Pulse steroid therapy is used in various severe or life-threatening rheumatologic conditions, such as systemic lupus erythematosus, SLE, particularly in cases of lupus nephritis or central nervous system involvement. Rheumatoid arthritis, for severe flare-ups or extraarticular complications. Vasculitis, such as ANCA-associated vasculitis, where rapid control of inflammation is essential to prevent organ damage. Systemic sclerosis, scleroderma, in cases of interstitial lung disease. Polymyositis and dermatomyositis to control severe muscle inflammation. Severe gout flares, occasionally used when other treatments are contraindicated. 4. Benefits. Rapid onset of action. Quick reduction of inflammation, often within hours to days. Disease control helps to manage acute exacerbations or prevent life-threatening complications, such as organ failure. Steroid-sparing effect. Pulse therapy may allow for lower long-term maintenance doses of steroids, reducing the risks associated with prolonged steroid use. 5. Risks and side effects. Despite its benefits, high-dose corticosteroid therapy comes with several potential side effects. Hyperglycemia, increased blood sugar levels, especially in diabetic patients. Hypertension, a rapid increase in blood pressure. Electrolyte imbalances, especially low potassium, hypokalemia. Increased risk of infections due to the suppression of the immune system. Psychiatric effects, such as mood swings, insomnia, or even steroid-induced psychosis. Gastrointestinal bleeding can exacerbate or cause peptic ulcers. Osteoporosis. Long-term steroid use increases the risk of bone density loss, though pulse therapy typically has less impact in the short term. 6. Monitoring. Vital signs, especially blood pressure and blood glucose. Electrolytes. Monitoring for imbalances like hypokalemia. Infection risk. Keeping track of any signs of infection as the immune system is suppressed. Bone health. In cases of recurrent or long-term pulse therapy, strategies to protect bone density, e.g., calcium and vitamin D supplementation, bisphosphonates, may be necessary. 7. Transition and follow-up. After pulse therapy, patients are often transitioned to lower doses of oral corticosteroids or other disease-modifying treatments, DMARDs or biologics, to maintain disease control. The goal is to taper off steroids to minimize long-term side effects, especially if the patient has had multiple courses of pulse therapy. Pulse steroid therapy is a powerful tool in rheumatology used for acute management of serious inflammatory episodes while minimizing long-term steroid exposure. Pulse cyclophosphamide is a treatment strategy used in rheumatology to control severe, life-threatening autoimmune diseases or vasculitis. Cyclophosphamide is an alkylating agent that suppresses the immune system by targeting rapidly dividing cells, including immune cells responsible for inflammation. Key features of pulse cyclophosphamide therapy. 1. Mechanism of action. Cyclophosphamide works by cross-linking DNA strands, inhibiting DNA replication and causing cell death. It particularly targets rapidly dividing immune cells, T and B lymphocytes, that are involved in the autoimmune process. This profound immunosuppressive effect helps to reduce inflammation and prevent tissue damage in severe rheumatic diseases. Part 2. Dosing and administration. Pulse therapy. Cyclophosphamide is typically given in high doses intravenously at intervals, often every 2 to 4 weeks, depending on the disease and patient response. Standard pulse dosing. Intravenous IV cyclophosphamide is often dosed at 500 to 1,000 milligrams per parameter of body surface area per pulse. The dose can be adjusted based on renal function and other factors. Duration. Treatment duration depends on the severity of the condition, but pulse therapy usually lasts for 6 months to 1 year, followed by a transition to less toxic immunosuppressants or biologics. 3. Indications. Pulse cyclophosphamide therapy is used for severe, life-threatening conditions where rapid control of inflammation is critical, such as systemic lupus erythematosus (SLE), particularly for lupus nephritis, kidney inflammation, or central nervous system involvement. ANCA-associated vasculitis, e.g., granulomatosis with polyangiitis, to control severe inflammation in organs such as the kidneys, lungs, or nervous system. Systemic sclerosis, scleroderma, in cases of severe interstitial lung disease or pulmonary hypertension. Severe rheumatoid arthritis, when refractory to conventional therapies and in cases of life-threatening extra-articular manifestations like vasculitis. Polyarteritis nodosa, a form of vasculitis affecting medium-sized arteries. 4. Benefits. Rapid immunosuppression. Cyclophosphamide is highly effective at suppressing the immune system and reducing inflammation, often leading to quick disease control. Preventing organ damage, especially useful in diseases like lupus nephritis or vasculitis, where delayed treatment could result in permanent organ damage or failure. Steroid-sparing effect. Cyclophosphamide allows for lower doses of corticosteroids, reducing the side effects associated with long-term steroid use. 5. Side effects and risks. Cyclophosphamide has significant toxicities, especially when used in high doses or for extended periods. Bone marrow suppression, leading to low white blood cell counts, leukopenia, which increases the risk of infections. Infections. Due to immunosuppression, patients are at higher risk for bacterial, viral, and fungal infections. Bladder toxicity. Cyclophosphamide can cause hemorrhagic cystitis, bleeding in the bladder, which is why hydration and the use of mesna, a protective agent, are often required to prevent this complication. Malignancy. Long-term use of cyclophosphamide increases the risk of certain cancers, especially bladder cancer and lymphomas. Infertility. Cyclophosphamide can lead to infertility, especially in younger patients, due to its effects on ovarian and testicular function. Nausea and vomiting. Cyclophosphamide can cause significant gastrointestinal side effects, though anti-nausea medications can help mitigate these effects. Alopecia, hair loss. Temporary hair loss is a common side effect during treatment. 6. Monitoring. Close monitoring is essential during pulse cyclophosphamide therapy to manage potential side effects and adjust doses accordingly. Blood counts. Regular complete blood counts, CBC, are needed to monitor for bone marrow suppression. Renal and liver function. Routine blood tests to monitor kidney and liver function. Urinalysis. To check for signs of hemorrhagic cystitis or other bladder issues. Infection surveillance. Patients are monitored for signs of infection and may be given prophylactic antibiotics, e.g., trimethoprim sulfamethoxazole, to prevent opportunistic infections like pneumocystis pneumonia, PCP. Combination with other therapies. Pulse cyclophosphamide is often combined with other treatments to improve outcomes and reduce steroid dependence. Corticosteroids. High-dose corticosteroids are typically given alongside cyclophosphamide at the beginning of treatment for faster disease control. Maintenance therapy. Once the disease is under control, cyclophosphamide is usually tapered, and patients are transitioned to less toxic drugs like azathioprine, mycophenolate mofetil, or rituximab for long-term disease management. 8. Fertility considerations. For patients of childbearing age, fertility preservation strategies, such as sperm or egg banking, may be considered before starting cyclophosphamide therapy. In some cases, gonadotropin-releasing hormone, GnRH analogs, are used to protect ovarian function in women undergoing treatment. Protocols and regimens. Several pulse cyclophosphamide protocols are commonly used, with slight variations depending on the condition being treated. National Institutes of Health, NIH, Protocol for Lupus Nephritis. IV cyclophosphamide, 0.5 to 1 grams per square every month for 6 months, followed by quarterly doses for 18 months. European Vasculitis Study Group, EVS protocol for ANCA-associated vasculitis. IV cyclophosphamide, 15 milligrams per kilogram every 2 weeks for 3 doses, then every 3 weeks until remission. Conclusion. Pulse cyclophosphamide is a potent and effective treatment for severe autoimmune diseases and vasculitis, but it requires careful monitoring and management to mitigate its significant toxicities. Due to its risks, it is often reserved for life-threatening or organ-threatening disease where other treatments are insufficient. Once remission is achieved, efforts are made to transition patients to safer maintenance therapies.